This is going to be your National Registry Skills Evaluation of the management of an apneic patient using all the equipment that you see in front of you. Take a second to look at your equipment to make sure it's how you want it and it's operational, because once we start, you will not have the opportunity to go back through and gather any more equipment. So we've done that. Please take the opportunity to do that. The only other thing that's missing from here is that you will have an oxygen cylinder here that you're going to be expected to utilize. Okay, well, I promise you're going to get that training before your skills evaluation. Okay, so I'm ready to go. All right, sir. Do you have any questions for me before we start? No. If you have any questions during your skill, based on the type of question you have, is going to determine whether or not I'm going to be able to answer that question for you. You need to hear verbal confirmation from me that you're ready to start. Okay, I'm ready to start. Okay, you and your partner are going to respond to the scene. Now, don't critique me because I don't have my gloves on. I should have my gloves on. BSI, yes?
No.
Right?
Not intact.
She's going to say, don't start it, Chuck. Okay, so you're going to be responding to the scene of a patient that is a suspected overdose. Family member calls in and says they think their son overdosed on some type of drug. Okay, good to go. Is my scene safe? Yes. My BSI is intact. My NOI, apparent possible overdose. Is this my only patient? Yes, it is. Due to the nature of the illness, I decided I'm going to call ALS. Okay, ALS is en route. Okay, I'm going to approach the patient. Appears to be a male, unconscious, unresponsive, in the supine position. Come up, I'm going to determine level of consciousness. Say, sir, you okay? Unresponsive to verbal. Sir, you okay? You all right? Unresponsive to painful. Okay, I'm going to start I'm going to get down here. I'm going to look, listen, and feel for the rise and fall of the chest, feeling for any air coming from the nose and the mouth. And while I'm here, I'm going to assess the carotid pulse for at least 5, but no greater than 10 seconds. Very good, candidate Gardia. At this time, your assessment reveals that your patient has snoring respirations at 3 to 4 times a minute. Snoring respirations at 3 to 4 times a minute shows me that I have a partial airway obstruction. Okay, what I'm going to do is I'm going to take my BVM using my CEC3 technique in combination of a manual maneuver with the head tilt chin lift maneuver, and I'm going to go ahead and ventilate my patient one breath every 5 to 6 seconds, looking for the rise and fall of the chest with every breath. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. Very good, candidate Gardia. If this were a pediatric patient, how often would you ventilate? If a pediatric patient, I would ventilate one breath every 3 seconds. Can you demonstrate? Sure. 1, 2, 3. 1, 2, 3. If this were an adult and you needed to hyperventilate, how often would you ventilate, candidate Gardia? One breath every 3 seconds. 1, 2, 3. 1, 2, 3. How often are you going to do this, candidate Gardia? I'm going to ventilate for at least 2 minutes, hyperoxygenate the patient before I move to the next. Maybe me oxygenating him will hopefully manage his hypoxic state. If not, we'll continue to move on. What is hypoxia, by the way, candidate Gardia? Hypoxia is the lack of oxygenation into the cells, into the tissue. Well, what's the difference between that and hypoxemia? Hypoxemia is the lack of oxygen in the blood. Okay, continue. 2, 3, 4, 5. What is that technique that you're doing there? I'm ventilating my patient. What's the difference between ventilation and respiration? Ventilation is the movement of air in and out of the lungs. Respiration is the patient himself taking a breath in, making the gas exchange, and then exhaling the waste product. Very good. Keep going. Okay, candidate Gardia, 2 minutes has passed. You reassess, and your patient still has snoring respirations at 3 to 4 times a minute. So he has an airway, but he can't keep his own airway. I need to manage that. It is a life threat, so I'm going to go ahead and manage that. So what I'm going to do now, I'm going to ask my partner, who's here with me, simulated partner, to continue to ventilate while I prepare oral adjunct. I'm going to go ahead and decide to put in oropharyngeal airway. Well, candidate Gardia, how do you know you can use an oropharyngeal? Well, the patient is unconscious and responsive, and I know he doesn't need to he can't have a gag, but I don't know that yet. But I'll find out when I actually put this in whether he has a gag reflex or not. Okay, very good. So I asked my patient partner to continue to ventilate. I'm ready to go. Check my equipment. I'm good to go. So I ask him to stop. I'm going to come in and I'm going to measure from the center of the mouth to the angle of the jaw, or I'm going to measure from the corner of the mouth to the earlobe. Okay? Once I've successfully accomplished that and have my right device, I'm going to assist by opening the patient's mouth, starting with the tip of the device facing the roof of the mouth. I'm going to insert from the side. Okay? Once I'm in halfway, I'm going to rotate the device 180 degrees until the flange is resting at the lips. Very good, candidate Gardia, but unfortunately you caused your patient to gag and vomit. So I'm going to remove the device by upward and downward position, making sure that I not take the tongue or any other soft tissue. No head, neck, or trauma, so I'm going to put the patient in the recovery position, allowing for the natural drainage of the emesis. Okay. While I'm here, I'm going to take my suction device, which we'll go over a little bit later, and I will suction the patient out. Okay. Once I've accomplished that, I'm going to put the patient back into the supine position to manage his airway. Because I've introduced an adjunct and suctioned, I've caused my patient to become more hypoxic, so I need to hyperventilate him, or oxygenate him, I should say, for another 2 minutes prior to insertion of the next adjunct. So again, using the CE-C3 technique, 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. Okay, very good. Unfortunately, candidate Gardia, your patient is still snoring. Okay, no problem. I need to get this airway done. So I'm going to ask my partner to continue to ventilate for me. Now I'm going to move to my next adjunct, which is going to be the nasopharyngeal device. But candidate Gardia, how do you know you can use that NPA? Well, my patient, I could use it on either unconscious or conscious patient. I know he doesn't have any soft tissue trauma to the face, and he has no head, neck, or spinal cord injury or head trauma, so I think I'm going to be pretty good. Okay, very good. Keep going. So I'm going to take my device, make sure I have my equipment. I'm going to measure this correctly from the tip of the nose to the earlobe, make sure that I'm satisfied there. I'm going to make sure that I lubricate my device up. I'm always going to start on the right side because it's the natural curvature of the device. I'm going to make sure that my bevel is facing the septal wall. I'm going to insert the device on the right side first, insert the device until I either meet resistance or the flange is resting at the nostril. Very good, but what would you do if you did meet resistance on the right side? I would take the device out, no need to ventilate here because it's going right back in. I'm going to go ahead and re-lubricate the device, move over to the left side, slightly extend the head. Again, with the bevel facing the septum, I'm going to insert the device. Once I pass the septal wall, I'll rotate 180 degrees until the flange is resting at the nostril. Okay. Once I'm doing that, I'm going to go ahead and continue to ventilate using a combination manual maneuver. Okay, did you call for ALS? I did call for ALS. Hey, my name's paramedic Yvonne. Can you give me a report, please, on what's going on at this point? Critical criteria information, critical criteria failure. If you unsuccessfully give an inaccurate report to the arriving ALS unit, critical criteria failure. Yeah, no problem. We arrived on the scene, found this patient unconscious, unresponsive with an apparent overdose. He was unresponsive to both painful and verbal stimuli. My primary assessment showed he was snoring at maybe 3 to 4 times a minute. So I started bagging him with the BVM, 1 breath every 5 to 6 seconds. We did that for 2 minutes, and unfortunately it did not have any positive result. So he continued to snore after 2 minutes. Asked my partner to ventilate, so we chose to drop a OPA in him. Dropped an OPA in him. Unfortunately, he had an active gag reflex, caused him to throw up. Put him in the lateral recumbent position, suctioned him. No aspiration noted. We cleared him bilaterally with his lungs. No aspiration noted. Okay. Once we did that, we put him back in the supine position, continued to ventilate him because we did drop his SpO2 a little bit, causing him to become more hypoxic. Okay. After that 2 minutes, he still snored after reassessing, so we decided to drop a trumpet in him. After we started on the right side, we were unsuccessful. He made some resistance on the right side, so we decided to put the trumpet in on the left side. Okay. Once we put it in on the left side, he accepted it pretty well, and here we are right now, and you arrived on the scene. Okay, good. Let's stop. Let's reassess. Okay. All right, he's looking pretty good. All right, well, do me a favor, candidate Gardia, paramedic, and says, hey, listen, he's starting to wake up a little bit. Let's do this. Let's get ready to transport this guy. Let's go ahead and put him on high concentration for the transport, okay? But I'm going to leave the trumpet in. Okay, good. So I'm going to put this non-rebreather. High concentration to me means non-rebreather mask. So I'm going to take the non-rebreather mask. I'm going to check my device first, checking any tears, kinks, or binds, making sure that that's squared away. I'm going to get my device, portable oxygen here. I'm going to plug it in, select 15 liters per minute, prepare the device by putting my thumb over the one-way valve, making sure that the reservoir bag is full. Okay, once the reservoir bag is full, then I'm going to go ahead and come over, placing the mask both over the nose and the mouth. Once that's okay, I'm going to use the claw technique or claw method to put the strap around the patient's head. pinching the nose piece in place, securing the straps. Once I'm done with that, I'm going to put the patient in a semi-Fowler position. Well, that's good, but I have a quick question for you. Can you tell me what makes that a non-rebreather mask? Yeah, sure. It's a non-rebreather mask because once this reservoir bag is full, this one-way port allows only 100% oxygen to come in as the patient takes a breath in. But these exhalation ports allows for the waste product to be removed, and when he breathes in again, they collapse, disallowing him to rebreathe his waste product in the form of CO2. Okay, good. So you guys are transporting. Paramedic says to you, hey, a couple minutes out from the hospital and stuff, I don't want to take this guy in with all this mess and stuff. He looks kind of janky. Let's go ahead and downgrade him. He's looking pretty good. Respirations 12 to 16 times a minute. Skin warm and dry. He's times 3 for us on his mental status. SpO2 96%. Let's put him on some supplemental oxygen. Get him into the ER. Cool. Turn off the oxygen. Take the non-rebreather mask off. Sir, coming out with the trumpet. Just relax, nice and easy. Good. So now I'm going to grab my nasal cannula. I'm going to check my nasal cannula, make sure there's no kinks, tears, binds. I'm going to select 2 liters. Do you want me to titrate that for you? Yes, titrate that for me. Okay, so I'm going to select 2 liters per nasal cannula for titration. I can go up to 6 liters with the nasal cannula. So once I get that in place, I'm going to come around to the anterior portion, making sure that the prongs are facing downward, placing them into the patient's nostrils, bringing these back around his ears, holding it taut, putting the slide in, making sure that the patient stays in the semi-Fowler position. Done. Easy.